I really care about every patient, and I want to make sure that no woman doesn't feel that they have access to this good health care, that we can make sure that people have access to this screening, that women know that their breast health is cared for, and that we're there to help them through this.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Amy Kerger. Amy is a James diagnostic radiologist and mammogram expert. Mammograms are vital in detecting breast cancer in the early stages when the success rate for curing this all too common form of cancer is extremely high. The James and Stephanie Spielman Comprehensive Breast Center are leaders in mammogram screening with one of the largest, busiest, and most advanced screening programs anywhere. Amy will fill us in on when and how often women need to be screened, the actual procedure and what it entails, the role of radiologists, and how the James and Spielman are leading the way and saving a lot of lives. Welcome, Amy.
Thank you, Steve. It's nice to be here.
Yeah, it's great to have you because this is a very important topic that really does save thousands of lives every year.
It does, very much, and I'm really excited to talk to you and the listeners about it.
Good. So when people who listen to this, by the time this podcast is over, women will know everything they need to know about mammograms.
That is our goal.
Okay. So I'm curious, can you give us kind of a brief history? I have no idea how long they've been around for.
So the first mammogram ever was performed in 1913.
Nice.
A physician actually started doing x-rays on mastectomy specimens to see if he could tell what the cancer looked like from the specimen. And from there, it kind of moved forward, and in the 60s really picked up speed, and that machine ended up becoming something that was created to be able to have in a center where a woman could come and actually get an actual mammogram. And they wanted to create it so it was low-dose radiation. And so in the 60s to the 70s, we started having places perform mammograms as screening in the U.S. and abroad. And then in the 1980s to 90s is when the U.S. started their screening program. And in the 1990s is when the FDA actually decided to enact the Mammogram Quality and Standards Act, which is an act that made sure that the quality of the mammographic pictures and the reports were standardized so that no matter where you went in the United States for your screening, it was going to be the same, and that the quality was going to be good for all women.
Wow, I hadn't thought about it, but that's important. Taking them is important, but reading the picture is maybe just as, if not more important.
Exactly. And so you want that to be the same. You want a woman to be able to go to any hospital and get the same care if we're going to have a screening program that is based nationally.
So I've talked to different James doctors about different kinds of screenings and how it takes a while to educate and get people, in this case women, to understand and to accept and get their yearly mammograms. It seems like it's taken a while, but now everyone knows about it, and it's just a common part of taking care of yourself.
Yes, and that was the goal of the screening program, is that women would know that yearly I should come and get a mammogram, and that mammogram could save my life. And one of the big things with a yearly mammogram is starting at the age of 40, which is what we recommend, and doing that every year has saved, and proven by the trials, has saved 40% of women from dying from breast cancer when we enacted this screening trials throughout the U.S.
That's 40% of millions of women.
Right, and you have to remember that 40% is of the women who came for screening. Now, there's many women who didn't come for screening. We probably have 20 to 30% of women today who still don't come for their yearly screening. But of the women that did, 40%, we saved their lives. If we find cancer early, it is treatable, and people go on to live healthier lives. But if you wait until it's palpable, or if there's some sort of symptom, sometimes then the treatments are harsher, and sometimes it's harder to save that woman's life.
Right, because it could have spread to other parts of the body, and it's much, much harder.
Correct.
A mastectomy, it wouldn't be enough anymore, or chemotherapy and immunotherapy.
Correct.
So the year is based on the growth rate of breast cancer, that if you get one in this year and you're clear, and no matter what happens a year from now, if you get cancer, it'll still be small enough that it's in that high rate of cure.
Correct. That's the goal, is to, if we do it yearly, we're hoping to catch it at a very early stage. Doing it every other year, which was a recommendation for the United States Preventative Task Force, that is when cancer could be doubling at that 2-year mark. So we want to catch it before it's doubled.
Yeah.
And that would be at a much earlier stage. And our mammograms have gotten so much better over the years. We've gone from, film screen, where if you think about your camera at home, the old cameras where we used to put film in the camera, you take a picture, then you take that picture and you take it to CVS, and then they will create your pictures from that film. That is what we used to do years ago for mammogram. They'd take a picture on a cassette, they'd stick it in a machine, that machine would then create a film, we'd have to hang the films and read them that way. And then you move forward to the 1990s, where full field digital mammography came about, where they'd be able to take that picture, and then that picture would actually electronically send into the computer, and the pictures were then digitized. And so then we could compare, and we didn't have all these films we had to keep on hand and look at. But the picture from the film to the digital picture was so much better. It was so much clearer, and had much better resolution. And now move forward to more recently, in the end of the 90s to the 2000s, we have digital tomosynthesis, which is basically taking a picture, but it's in a 3D kind of picture. We are using CT technology to create tomosynthesis. So when we look at that, we're not just looking at it in a 2D picture, but we're able to scroll through the breast and look at it in slices. And the beautiful thing is, because of our technology, we're able to take those tomosynthesis images, and then the computer can create those images into a 2D picture, so we can look at the same 2D image that we used to get. And we can also use that 3D image to be able to find more cancers. It has decreased us calling back women, because we used to have to sometimes call them back because we'd see something, we had to go.
But you weren't sure.
We weren't sure. Now, we still call women back, don't get me wrong, and sometimes it's still nothing, but it's 40% less of that callback where it ends up being, a false positive, where we think we might see something and ends up being nothing. Now we're a lot more accurate because of that, and we're finding more cancers at a much smaller stage. So it's really moving the bar to even better screening, and the radiation exposure to the woman is exactly the same as it was with the full field digital.
Ooh, I want to get to that and how small you can see, but first, before we get to that, so sort of explain the technology, because you said, it goes back more than 100 years to a X-ray. So what are sort of the big advances, and where are you now with the technology you use? Because I know there's a couple different ways to do it now.
So for mammogram screening, we do all at the James and Stephanie Spielman Comprehensive Breast Center. We do all of even our mobile technology is all tomosynthesis. We do all
3D.
digital. We all do that. We can, and then we can create that 2D image from those 3D pictures, and we use that in the screening realm, and we use it in the diagnostic realm. For the diagnostic mammogram, that's a little different mammogram than screening. Screening, you come in, you get a couple pictures, and we read those. You go home, and we read them, and you get a report. The diagnostic piece is if I called you back from your screening because I saw something, or if you went to your doctor and you had a palpable lump or a nipple discharge or something else that was concerning, and they sent you in for a mammogram. Still the same process. We're still using the same equipment, the same process, but we may be taking a couple extra pictures, and we, the radiologist, would be looking at those pictures before you left to add on extra pictures if we needed more, and or doing an ultrasound at that point in time for the diagnostic purposes. Now, we do have other screening methods for women, but those are for the population. Mammogram is the standard. That is the best thing, because it's low dose radiation. It's paid for by their insurance. It's something we can easily have them get, and it's low risk with a high benefit. We can do ultrasound, which has no radiation. We can do whole breast screening ultrasound, but that is only approved for women with dense breast tissue. So heterogeneously dense or extremely dense breast, which is 50% of our population. It is an added screening supplemental, not the first line. Mammogram's still the first line, because ultrasound...
Even for women with dense breast tissue, they would first get a mammogram.
Correct.
And then
Then
what would make you do?
So if they have dense breast, they would get a letter when they get their mammogram report saying, you have dense breast parenchymal tissue. Dense breast have a small increased relative risk to the regular population, but it also has a risk of masking, meaning a mass on a mammogram looks white. Breast tissue on a mammogram also looks white. It's kind of like if we go out in your yard when it snowed and I take a snowball and I put it on your lawn and I tell you, hey, Steve, come on outside and find the snowball. You're not going to be able to find it. But masses are not the only thing on a mammogram that shows you cancer. Sometimes groups of calcifications, certain types of calcifications can be concerning for cancer. Architectural distortion can be concerning for cancer. So there's other things we look at that does show up well on a mammogram that you would not see on an ultrasound.
Oh, so that's why you do both.
That's why we do both. So in the dense breast parenchymal people, we're more likely on mammogram to possibly miss a mass because of the snowball analogy, which is why we would then use ultrasound, which is much better at helping us see through that and finding those masses if there's anything in there that's concerning. But the patient then needs to also check with their insurance provider to see if they cover that as a supplemental screening. Some do and some don't. Some still you have some sort of copay you'd have to pay for or something. So we encourage patients to check with their insurance provider and talk to their primary care physician or OB-GYN about whether they think that this is something that would be beneficial for them to add as supplemental. Because the other side of it is if they talk with their PCP or their OB-GYN and they find out that they're high risk, they have a 20% or greater risk of breast cancer by family history, by many other reasons in society why we would have that. You're overweight, you're smoking, had a baby later in life, had your periods, or there's lots of different things.
The BRCA,
yes, and all of the genetic
Yeah.
mutations. If you are in that high risk, then we recommend mammogram and MRI yearly. MRI, again, is not something that's recommended in the regular population for screening because insurance companies don't pay for that usually for dense breast or just the regular population under a 20% lifetime risk. So it's a more expensive test. So patients don't want to pay out of pocket.
Yeah. We're going to take a quick break, and when we come back, we're going to dive down and learn a little more.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back, and Amy, I thought it might be important. Let's talk a little bit more about what would make a woman high risk for breast cancer, because I think that's really important to know.
So some things, there's a laundry list of things that we look at when we try to evaluate whether somebody is in the high risk category for breast cancer. One of them is obvious of family history, mostly first degree relatives. And
sister or parent.
Sister, mom, dad, brother.
That's true. Men can get breast cancer.
Men can get breast cancer. It's less. It's only about 1% of the population, but men can. And then if you have a large number of second-degree relatives, grandma, aunts, uncles, that might contribute. That's also could be a factor. And then there's lifestyle, reasons for being a little more high risk. Those, are additive of, smoking, obesity, pregnancy at a later age in life, periods early in life, hormone therapy. There's a bunch of different things we would look at. So it's hard sometimes, or if there's a genetic mutation for breast cancer in your family, that obviously, would maybe put you at a high risk category. So when we consider high risk, we say you have a 20% or more lifetime risk of getting breast cancer at some point in your life.
What would be the normal lifetime risk?
Our normal lifetime risk is probably 8%.
Okay, so high risk
so it's higher.
Is more than double.
Yeah.
Okay.
So for patients, if it's very hard because you don't know. I just gave you a whole laundry list that didn't probably even include everything. So what they need to do is have a conversation with their PCP or their obstetrics gynecologist and discuss, do you think I'm high risk, if they think they might be. And if they're still unsure or would like to actually speak to somebody who does this on an everyday basis to get more extensive look at their risk profile, they can come at the James Stephanie Spielman Comprehensive Breast Center. We have high-risk providers who see patients who may be at high risk, and they will go through their entire history, go through everything, and decide, help them decide whether, okay, yes, you are high risk. Now, what should we do about that high risk category? What kind of supplemental screening? What are other things that we need to do? Do we need to run genetics for you because maybe you are in that risk category? One of the things a lot of patients will say to me when I recommend a biopsy is that, I'm not worried because I have no family history of breast cancer. And though family history does put you at a higher risk, it does not mean you won't get breast cancer.
Yeah.
And only about 15 to 20% of breast cancers are people who have genetic mutations. So, and are in that high risk category. So 80% of the time, it's just something that happens, and they're the first person.
Wow. So I've never actually seen one done, obviously, because I don't get them. But walk us through what it's like for a woman going in, the prep, the actual screening, and is there anything afterwards?
Yeah, so that's a really good question. And so when women come into the center, obviously, they're going to get registered, and they would come upstairs, and the technologist would have them go change and disrobe from the waist up. Then we give them a nice robe to put on, and the technologist would take them into the room to get the mammogram. We usually ask patients before they even come in, don't wear deodorant under the arms, don't wear lotions or talc powder, because sometimes those things can actually show up on the mammogram. If you show up that day and you have it, we do have wipes to try to wipe that stuff off, but we ask patients to try not to do that before they come in. Also, if you are a woman that's prone to having tender breasts at certain times of the month, it'd probably be best to not schedule your mammogram at the times when your breast might be the most tender during certain parts of their menses cycle. And I will get back to whether mammograms cause pain, but I do recommend that if women have more painful breasts, it's just better to do it at a time when they're usually not as bothered. Once the technologist gets the patient in the room, they'll ask quite a few questions of, when was your last mammogram? Where was it? If it was somewhere other than where you're at Ohio State, we'll ask you to sign a release so we can get those priors. Prior mammograms are really important for us, the radiologist, because we want to compare year to year so we can see if there's changes. If you have them, on a disc at home, you bring them with you, they'll get them uploaded, but we'll make sure that actually occurs. And they'll also ask them for a provider they'd like the report to go to, so their PCP or their obstetric gynecologist. And then they'll ask some questions about, family history and some risk factors. And we actually run a small, quick, high-risk calculator so that if you are considered high risk by our calculator, it will go into your report so you'll know, like, hey, you've been flagged as having a higher than normal risk. So maybe you'd like to go see the high-risk clinic. And so that would go on your report. So all of that will be done, and then the technologist will explain to you what they're going to do, but they will have the machine set up. They will place you into the machine, get your breast set into the machine. The machine then compresses the breast. We do two pictures.
You're standing
You're
up?
standing, unless you can't. We can do these seated, but they're better to do standing because we can actually.
If someone's in a wheelchair, or
we can work around. If somebody's in a wheelchair and can't stand, we absolutely can work around those things. But if they can stand, it's a better picture because we're able to get back and more tissue into the picture. So we're trying to get as much tissue into the picture. So the technologist is going to work to make sure that picture looks the best. As we said, there's a quality and standard act, so we are held accountable to make sure we get the best pictures. So the technologist will compress the breast, and then we'll go back and take the picture. We'll let you know how long it's going to be, and then automatically the paddle will come up and uncompress the breast for you, so you're not stuck in that any longer than need be.
It's just a few seconds.
Yeah. So each picture is a few seconds. We do 2 pictures each side. If the picture if we do one picture and it's blurry, or the technologist thinks they didn't get a very good picture, they're going to ask to redo that.
Because you can see in real time to make sure that it's clear.
Correct. And movement, so they're going to compress that breast. We want really good firm compression. You don't want to be in utter pain, but a mammogram should be somewhat uncomfortable, because if they're doing a good job, that compression should help keep that breast stable, because so you don't have like when you take a picture with your iPhone, if your kid's
right.
bouncing around, it's blurry. Same thing happens here, and we can miss things on the mammogram if they're blurry. The second thing is, the better the compression, the more they can spread out the tissue of the breast, helps us see what's
more,
underneath
yeah,
that there.
Instead of it's a wider circle.
Right. So we're going to do 2 pictures each side.
And those 2 pictures do the tomography where it's 3D,
Mm-hmm. Yep.
even in that quick second.
Takes just a few seconds.
But it takes lots of pictures.
Yep, and they'll ask you to hold your breath, so we have a quick breath hold so that the breathing doesn't cause movement, right? And then you're done. And most women do ask, do mammograms cause pain? Like I said, they should not be comfortable, but they should not be the most painful thing you've ever had done. And when they're done,
the pain goes away.
Pain goes away.
So, as someone who reads these, what's that process? When a woman gets it taken,
Mm-hmm.
when does it go to you, and what do you see? Like, how do you described a little about what it looks like, but give us a few more details on that.
So for screening mammography, when you come in and you get your pictures taken, they go automatically on our work list once they're completed and the patient's gone. We read most of our screening same day. The only time your screening exam would not probably get read same day is if it's done after hours, like 5 or 6 p.m. or later, or if you have prior exams from another institution that we need to get.
that you're waiting,
So
yeah.
those will be held only for 2 weeks. The other institution, we will reach out to and ask for them. They have no legal ramifications if they don't send them to us. Most will send it without a problem, but if for some reason it doesn't get to us, at 2 weeks' time, we will read those, because by a month we have to have a letter out to the patient. So 2 weeks would be the longest you'd wait if we didn't have your priors. But like I said, we don't run into too many where we don't have them. Most of the time, that's if it's out of state. So if you're coming from out of state, I recommend it before you move, if you can, bring your pictures, because it's a little harder to get the out of state things. Not impossible, but that's where I see more of them, where I have to say we couldn't get them.
And that would be the
reading it.
first year of the women getting their mammogram here. The second year, you'd already have that stuff,
Correct.
so there wouldn't be that.
Right. And we upload anything from any priors from somewhere else. We upload it into our system, so we'll have that then as you come yearly. Once it gets to me or one of my colleagues, we read the exam and we report it out. And in that report, we're going to tell you what is your breast density, because that's going to trigger that letter to tell you if you have dense breast. Then
is that an actual number, or is it yes or no?
It is. There's 4 different categories. It's fatty replaced, scattered fibroglandular, heterogeneously dense, or extremely dense. So heterogeneously dense and extremely dense are in the dense category. The other 2 are the non-dense category. And it can change from year to year. There are different things that weight gain, weight loss, different medications, all kinds of, just aging can change it. Hormones change those things, pregnancy. So for one year you may get one, and the next year it may say something different. So that's not uncommon. Most women, if nothing major is happening in their life, it stays pretty consistent, but it can change year to year. You have a 20-pound weight loss, you may have gone from scattered fibroglandular to heterogeneously dense. So we'll tell you that. We're going to tell you if there's anything going on. We'll mention benign things. We'll talk about benign calcifications. Calcifications can be benign. We know the difference between the benign ones and the not benign ones. There may be masses that are benign in your breast. Cysts. If there's a whole bunch of them scattered and they look the same as they always have, that's a benign mass. Or, and if you've had a prior biopsy or prior surgery, we mention those things sometimes in there. And if there is something we need to call you back for, we will talk about that. Now, the moment I sign that report, if you're a MyChart user, it goes right into your MyChart and you will see it immediately, which is now a law that all of those reports have to get sent directly to the patient immediately. So if it's a benign report, you also will get a letter in the mail within a couple weeks. If it is something we have to call you back for because you need to come back in for more pictures and possibly an ultrasound, you're going to get that in the report. And then one of our technologists will call you to help you schedule that.
So you'll see it first in MyChart, and you'll also get a phone call within a couple days.
Yeah, usually it's same day, if not the next day. If
Because
it's
you don't
later
want
in the
people
day.
worrying for too long.
Right. So we like to get people scheduled as quickly
Yeah.
as possible and not allow them to have to worry about that. And now we have, the ability to we have screening all over the city, and we have the mobile vans that also go to certain places to help people get screened. But we also have some diagnostic abilities. Obviously, at the Spielman Center, we do diagnostic mammograms and workers, but we also have a clinic that we do screening and diagnostic 1 day a week out of at Grove City, and one at Worthington, and then one in the new outpatient care Dublin. We have 1 day a week. We're in each of those locations.
So making it easier for women to get to where they need to be. You don't have to travel as far.
Correct. And making sure they can get in to get those diagnostics, because you don't want anybody being scared because we called you back for something. We want to be able to figure out what it is and get you moving, so we have answers for you.
Now, you've already sort of answered this question, but I'm going to ask it anyway. It seems like the James and the Spielman combined, being a comprehensive cancer center with amazing list of specialists and a high-risk clinic, a diagnostic clinic, the best plastic surgeons and surgeons. Like, what are the advantages that the Spielman offers women?
So you kind of said it yourself.
Yeah.
we're all specialists in this field. Whether
you only read breast
I only
mammograms.
read breast imaging.
Yeah.
We only do the breast biopsies. I don't do anything outside of that in radiology. I only focus on the breast. Our breast surgeons, are very specialized in breast. Our radiation oncologists have specialty in breast. Same thing with our medical oncologists and our plastic surgeons. So we are all come very specialized for breast health. So we offer that as a wonderful service, because when you come there, you're getting people that this is what we do all the time, and we know this part of medicine very, very well. On top of that, my technologist, my mammo technologist and my ultrasound technologist, this is what they do. They don't take x-rays of anything else or do ultrasounds of any other body part but the breast. And so they're there to help women through this process. And they're wonderful people who are very caring. And, you don't find always that you go someplace and people kind of understand what you're going through. But I feel like at the Spielman and the James, we understand what you're going through, and we're there to help you through that.
Yeah, and again, I feel like you've already answered this question, but in addition to your being a diagnostic radiologist, I know you're very passionate about education and making sure women know the importance of mammograms and get access to them. But what motivates you to do all this?
Well, because I really care about every patient, and I want to make sure that no woman doesn't feel that they have access to this good health care, that we can make sure that people have access to this screening, that women know that their breast health is cared for, and that we're there to help them through this. And it's a scary thing every time a woman comes and gets a mammogram, whether they've had breast cancer before or not, because, and if they get called back, it becomes even scarier. And we want to make sure that women know what they should be doing for their health and help them have access to that, and help explain it if it's confusing, so that we make sure that they're making the right choices for their bodies.
If someone listening to this is 40 or over and hasn't had a mammogram or wants to come to the Spielman to get a mammogram, how can they connect with the Spielman and schedule a mammogram?
So you can call to schedule a screening mammogram at the James line at 1-800-293-5066, or you can call just to schedule a mammogram at 1-800-240-4477. So if they get online, they can look up the Spielman Center, or you can look up OSU James Mammography. It'll list all of our screening sites out. They can then call and they can schedule that way. Or if they are a MyChart user within Ohio State, then you can actually schedule through MyChart also.
Thank you, Amy, for filling us in for all this great information, and hopefully we can get that rate up to 100% of women get mammograms, and we can eliminate death due to breast cancer.
That is my goal, Steve, and I'm so happy that you had me on today, and hopefully this helped a lot of women and answered some questions and will help more people come and get this great life-saving screening exam.
I think so.
Thank you.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.